start because it's just gone 2 o'clock. So thank you for taking the time to join me today. I appreciate how busy you all are, and I hope today you will help you plan for the year ahead. For those that don't know me, I'm Claire, and I've been a practice manager for over 20 years. I am an accredited member of the Institute of General Practice Managers, the appointed locality development lead for Salford, which focuses on non-clinical training and wellbeing for practice managers. I'm a trainer for GP Excellence, and I am passionate about primary care, staff training, and making sure that staff have the support they need. Before we start, just a few housekeeping points. Cameras are optional, but try and think this as a face-to-face training. Please ensure that you're on mute unless you have a question or when interacting. I am on my own today, and I will not be able to easily switch people to mute. Please share your thoughts, interact and ask questions. This makes it a positive experience for everybody. Remember, there's no such thing as a stupid question, and I always find that when someone asks a question, others are thinking the same thing. Please use the chat function or raise your hand if you have any questions, and if you do get disconnected, just rejoin. So, an overview of the changes. So from a practice manager's point of view, general practice is tough enough with dealing with the day-to-day running of things. When you add in the managing of finances, it can make the role even more challenging. How much this affects you will depend on your role, but it's important that we all have a basic understanding of how the contractual and QOF changes impact your practice and the decisions you make in the coming year. It's probably not the most exciting topic. For some it might be, but hopefully today's session will give you a clearer picture of what's changing and what this means for your practice in real terms. I'm going to start with a quick overview of the 26-27 GP contracts, and then I will go into more detail as we go through the training. The 26-27 contract builds on recent changes, which reflects ongoing engagement with GPs and primary care teams and aims to support sustainability of practices and workforce stability. The key strategic aims are to grow and stabilise the workforce, so more GPs and a better use of the wider teams, improve access and faster responses and more timely appointments, deliver more care closer to home with reduced reliance on hospitals. It strengthens prevention and population health with a focus on early intervention and long-term conditions, and continues digital transformation with a move away from paper-based and analogue systems. The overall approach is to simplify processes, target funding where it makes the biggest difference, give practices more flexibility to respond to local needs. And it's about strengthening general practice, improving access and giving patients more control. Practices, not patients, more control, but with clearer expectations on delivery. So we're going to have a look at the GP contract finances. So NHS England has said that the 26-27 contracts add 485 million, taking the estimated contract value to 13.863 billion, with a 3.6 cash growth, but in real terms, this is only 1.4% to practices. At the same time, this is politically contentious. The BMA says that the contract was imposed, and in its recent referendum, 98.9% of GPs voted to reject it. So why does this matter? Local implementation may be affected by professional resistance and messaging from the BMA and your LMCs. There are talks about GP practices going back to the work to rule, which, if you remember, we did last year. Until the contract is agreed, then there is talks about the work to rule, but at the moment, there's nothing in the pipeline. However, at present, we need to focus on the changes within the contract and how this affects your practice and your finances. So what do the changes actually mean to your practice finances? The 485 million is not new funding. It has been moved from other sources. So 80 million has been moved from the advice and guidance, with an additional uplift of 2 million in 25-26 added to this. It includes a pay assumption of 2.5%. However, there is a 3.5% recommendation by the DDRD, which is the review body on doctors and dentists remuneration. Key takeaways for practices: treat most of the uplift as a cost covering, not service expanding, and expect high margins unless list growth or efficiency savings offset cost. So in terms, it's going to be a bit of a tough time for general practice. So improving GP capacity is part of a contract. A major change is the practice level GP reimbursement scheme, funded by 292 million, repurposed from the PCN capacity and access payment. The funding is intended to let practices recruit additional GPs or buy more sessions for existing GPs in your practice to support same-day urgent access. This equates to approximately 0.26 whole-time equivalent GPs per practice, which, if you think about it, if you're a big practice, is not that much. The existing capacity and access payment have been removed from the network DES. To support the understanding of demand in general practice, data will be collected against 5 access metrics, and practices are encouraged to use this data to improve services for patients. So what we're going to be monitored on by NHS England over the next year is call waiting times between 8 and 10 a.m, call waiting times during core hours, the percentage of clinically urgent cases as deemed by your practice seen on the same day, the percentage of non-clinical urgent cases seen within 1 week, and the percentage of non-clinical urgent cases seen within 2 weeks. There's also changes to the ROs, so PCNs can now use the ARS funding for a wider range of GPs, not just recently qualified GPs, and the reimbursement ceiling has risen to the top of the salaried GP pay range, plus on cost. PCNs may also recruit a broader range of ARS roles where it's been agreed with your ICBs. The incentives and vaccinations and immunisations. There are 18 extra points in QOF, which are worth approximately 25 million nationally. The key changes are updated childhood vaccinations indicators to reflect the new MMRV, a new diabetes indicator requiring all 8 NICE recommended care processes, 2 new obesity indicators with the weight management enhanced service retired, updated heart failure indicators reflecting the 4 pillars of treatment, and extra improvement thresholds for the free childhood vaccination indicators. We will be looking at the QOF changes in more detail later on, so we will go into that a lot more detail. So vaccination changes for the practice. So practices that have care homes and patients, your PCN must ensure that your residents in the care homes are identified and offered seasonal routine vaccinations. Your PCNs do not necessarily need to deliver them directly, but they just make sure that there's arrangements in existence. The network contract DES now allows practices to collaborate on flu and COVID-19 delivery under the DES, where they want to, meaning the responsibility has moved away from the PCN to your practice. The RSV programme has been expanded to all adults aged 80 plus and all residents in a care home for older adults, with an item of service fee per vaccine being paid to practices. So actions for practices: review your vaccination operation model, your care home data, look at your consent and your processes, and any PCN collaboration arrangements to make sure you are targeting your patients that are entitled to these vaccines. Advice and guidance becomes part of the core contract worth 82 million, and all payments will be made via the global sum. I had a quick look this morning at my global sum, and in the April payment, there's nothing shown as yet for this payment, so watch this space. Practices will be required to use the advice and guidance before or instead of planned care referral, excuse me, where clinically appropriate, and to follow local referral pathways. The existing advice and guidance enhanced service has now been retired. So what are the implications for the practices in regards to the advice and guidance? Expect tighter referral governance, more pathway standardisation, and possible pressure to evidence appropriate use. And as you all know, the advice and guidance forms part of the B Core this year, so there'll be a lot of scrutiny on practices. So the core contract changes include lung cancer screening. So practices must now engage and share data with the screening programmes. Staff survey, NHS staff survey is to be rolled out across practices and PCNs when funded, with tailored workforce planning reports provided. GP registrations is moving towards digital patient registration, including approval for changes to the digital catchment area. Subcontracting rules, so it aligns the PMS and GMS regulations, giving commissioners equal powers to object to subcontracting. And the ICB collaboration, practices must work with integrated care boards where there are concerns or unwarranted variations or risk of breach of contract. Data access and monitoring, practices must provide timely data to NHS England, and this can include your online and video consultation info, but they can ask for a whole host of information. Patient choice of pharmacy. So patients must be allowed to choose their pharmacy for prescriptions and clinical service referrals, for example, your Pharmacy First scheme. GP email requirements. Practices must maintain an up-to-date email address, and this needs to be monitored throughout the day. So I've seen someone's put something in the chat. Yes, so Shazzy has asked a question around the online and video consultation. Most of that information should be, Karen's. So you've got your G-pad as well. So a lot of information is on there. So going back to the core contract changes, so no call back on another day. So practices must not ask patients to call back or make contact on a different day. This is now seen as a breach of contract. Same day access for urgent cases. Clinically urgent request must be handled on the same day, but I must stress that this is what your practice deems as urgent on the day. There should be no cap on the online consultations. Practices must not limit the number of online consultation requests during core hours. So it must be switched on from 8 till 6:30, Monday to Friday. So clear communication of opening times. So your practices must clearly display opening times, and this information must be available in your surgery, on the website, and in patient materials, for example, your patient booklets. All access modes should be available during core hours. This includes your phone lines, your online triage, your doors, etc. Any questions before we move on to the PCN DES? No? Okay. So the key changes to the PCN DES, we've already touched on some of these, but just to clarify the changes to this. So the ARS roles, which is the additional roles reimbursement scheme, PCNs can now claim reimbursement for GPs at any point of their career. This increases the funding caps, and the recruitment of non-patient facing roles may be allowed, but with your ICB approval. Continuity of care risk stratification becomes a core requirement. Continue focus on identifying and managing priority patient groups. Collaboration with your ICBs and your neighbourhood PCNs must work with the ICB and partners. The aim is to better alignment with PCN patient registration lists and local neighbourhood populations and priorities. Cancer and screening requirements, strengthen cancer and high priority non-cancer programmes, increase the use of safety netting tools and efforts to improve screening uptake. And your flu and your COVID vaccine collaboration, removal of the previous exclusions enables practice level delivery of the COVID-19 vaccines. The change is technical, but supports more flexible vaccination delivery. And I'm sure with the spring boosters that you're already delivering this. So what does this mean for your practice? So it's increased funding available. So there's 292 million in the scheme that supports hiring additional GP sessions. However, the supply constraints remain. There are not enough GPs nationally to meet the demand. Mismatch risks, funding does not guarantee successful recruitment. And practices will need a strategic workforce plan to manage this gap effectively. So just seeing that there's a message, clinically urgent patients must be managed on the same day. But remember, it's what your practice deems as urgent. We all work differently. No deferral allowed. Practices can ask patients to call back later. No caps on access. It must be switched on between 8 and 6:30 Monday to Friday. Your performance oversight access will be monitored using defined metrics. And the operational impact, less flexibility in demand management requires robust, structured, urgent care processes. If you're not already doing this, I would ask you to take a look at what you're doing in your practice just to be prepared for this. The ARS flexibility will increase competition. So if more of us are going to be looking at our roles and recruiting GPs, it's going to intensify competition locally. It probably will make the market a little bit volatile. So there's likely short-term instability in GP availability and salaries, maybe a lot of competition out there as well. And then your planning implication is going to be a continued need for interim and sessional workforce planning. So we all know we need our locums, but it's just planning where we will need that and making sure that we've got them in plenty of time. With the changes, the ICB oversight is strengthened. So there is going to be tighter monitoring. It's going to be greater scrutiny of access metrics using urgent care performance and variation between practices. There's also going to be targeted support. Underperforming practices may be required to work with the ICBs. And there's going to be strategic implications as well. So emphasis on early proactive stabilisation rather than reactive intervention. So in summary, funding structure and cost pressures, notably the PCN level capacity and access payments will be replaced by practice level GP reimbursement scheme. The shift may affect your cash flow as practices that previously received the capacity and access payments monthly via their PCM will now have to claim this reimbursement, and it potentially could lead to delays in the payment being received at the practice. Advice and guidance payments are now being absorbed into core funding. And with the wage pressures exceeded assumption of the 2.5% pay increase, we all know that the national minimum wage went up by 4.1%, and the DDR recommendations of 3.5%. This will definitely drive a rise in the monthly staff costing with potential cash flow strain in the practice. In summary, your practice may feel a squeeze on the practice finances. I certainly have been doing some cash flow projections, and I can see there's going to be a lot of pressure this year for my practice. So any questions on the contract changes before we take a look at the QOF changes? Only 1 year out of the QOF, obesity has returned, although it does look very different to previous years. There are two separate indicators. The first is OB004. This largely replaces the weight management enhanced service from 25-26, and the overall funding remains about the same, but there is a much higher requirement for referrals, and so the payment per patient referred to the weight management is smaller. The requirement for the OB004 is that the patient has a measured BMI of over 30 or over 27.5 for patients with a non-white ethnicity. There should be a referral to the weight management team within 90 days. And as usual, it applies to patients who could have had a referral during the year. So this could apply to people that have had a BMI recorded in the previous QOF year, which is not great for us. It is time limited, and the referrals need to be within 90 days after a BMI reading. However, if you do miss the window for the referral, you should make sure that the patient comes back in, has an up-to-date BMI, and that the referral is made within 90 days. There is exception reporting available for this indicator. As well as the usual reasons for exception reporting, this includes patients declining the referral or being unsuitable. There's also an opportunity for exception reporting if the service is not available. We believe that there are going to be some services unavailable because we feel that there's going to be a lot more patients being referred for weight management. The thresholds have been lowered as well in this indicator, running from 10% to 30% of patients being referred to get the full 5 points for this. Overall, the payment per patient referral is likely to be around £4, but that's not been confirmed as yet. The second obesity indicator, which is OB005, is quite different. This only applies to patients that are entitled to get the tirzepatide injection. For 26-27, this is for patients with a BMI over 35 or 32.5 in patients in non-white groups and 4 out of the 5 specified chronic conditions. And that includes type 2 diabetes, hypertension, sleep apnea, hyperlipidemia, or any other lipid-lowering therapy. So they might have high HDL or high LDL and cardiovascular disease. The 3 things need to happen in the year to be coded to meet the criteria for this indicator. First, a shared decision conversation needs to take place. Secondly, there needs to be a referral to behavioural support programme. And finally, there should be a record of a prescription for the weight management drug. There are 13 points for reaching 80% on this indicator. While the numbers are difficult to calculate at the moment, the payment per patient is likely to be around or between £100 and £200 per patient. The important thing will be to identify the patients earlier on and review the patients and make sure that they do come in for that shared decision-making consultation. So diabetes changes. So there are extra points have been added to the indicators for DM034 and 035. They've increased from 4 to 8 and 2 to 8. This is looking at the cholesterol and lowered lipid therapy in patients with diabetes, and it applies to both primary and secondary prevention indicators. There's no change to requirement for the indicators, so this should be quite good news for practices. In regards to the new searches, do you mean, Victoria, for the QOF? I assume, yeah, QOF. They usually come on in May, so hopefully we'll get them soon. So new diabetes indicator, which is DM037. This is 10 points where 75% of patients have had all 8 care processes within the QOF year. So the processes are, and I'm sure you're all doing this already, is a BMI recorded, the blood pressure, HbA1c, total cholesterol, smoking status, foot examination, and your albumin creation ratio measurement. Also included in this is the EGFR. Exception reporting is available, but will primarily be with the patients who did not attend their diabetes review, but you have invited them twice, at least 1 week apart. And this is a little bit of a change from last year. Heart failure. So the treatment for patients with heart failure with reduced ejection fraction, so your HFrEF, has changed significantly over the last few years, and QOF started to look a little bit out of date. And I know some of my GPs have been moaning about this for the past year. Up to now, it's only suggested that the use of beta blockers and the ACE inhibitors are similar drugs. The points have been allocated to a new indicator, which is HF009, which requires prescription of the following. So a beta blocker, which is normally a cardioselective, an ACE inhibitor or an ARB, or your sacubitril or your valsartan, your mineralocorticoid receptor antagonist, for example, your spirolactone, and an SGLT2 inhibitor. It's going to be really tricky to exception report, but it is available. In the case of patients being unsuitable for medications or choosing not to take them, because we've all got them patients, they must be prescribed all the other medications in order to be exception reporting. So, for instance, if a patient did not tolerate a beta blocker, then there should be a prescription for an ACE, MRA, or an SGLT2 inhibitor before you can actually exception record them. For many practices, they may already have been prescribed. So if you have got your patients that are not tolerant of certain medications, you will be able to accept and report them. The upper threshold for points is relatively modest, is at 50%, so it does look quite achievable for practices. But there is one other difference that is very important to know. In previous years, the code to add to get my words out, echocardiograms was left ventricular systolic dysfunction. This has changed, and the only code that's now going to be accepted is heart failure with reduced ejection fraction. You must look through your patients that were coded as left ventricular systolic dysfunction and ensure that the new code has been added. You'll probably find when the new QOF comes out, you'll have quite a lot of patients that will be on this list. Again, just look through, make sure that the correct code has been put on. So new cardiovascular disease and blood pressure areas, there were previously very similar blood pressure indicators in the coronary heart disease and stroke TIA areas. These have now been combined and the points have been pooled. There's no change to the blood pressure target, which are 140/90 for patients under 80 and 150/90 for older patients. The thresholds also remain the same. Patients recorded as having moderate or severe frailty have now been excluded from these indicators. The last coded frailty entry before the end of this year is the last one that is used to put these patients onto your list. The coronary care disease, CHD, and your STIA areas now only have a single indicator in each, which concerns your antiplatelet or your anticoagulant therapy, and these have not been merged, so these are completely separate. Hypertension indicators. The existing indicators have been updated to HYP 010 and 011, with patients with moderate or severe frailty being removed from these indicators. It does allow a more personal plan to be created for these patients that have got moderate or severe frailty. So it's not a huge change from this. Atrial fibrillation, so the upper threshold for patients with AF and a calculated CHADS-2 score in the last year has been increased to 95%. This is primarily an administrative activity. Clinical systems can easily calculate the scores, and this should be easy to calculate for your GPs without patient contact. Although if a patient scores 2 or more, they will need it to be acted upon. Even though the upper threshold has risen, the achievement from 24-25 was nearly 98% for the majority of practices, so hopefully it won't be a problem for us. So childhood vaccination indicators have been updated. So the only changes to the contents of the vaccination and immunisation indicators have been the addition of the MMRV vaccine, which was introduced at the start of this year to add the Varicella into the MMR vaccine. Although the suggested timing of the vaccines have also changed, this has not been reflected in the indicator, and this is likely to remain the case as children work through the new schedule. So you might look pretty bad at the beginning of the year, but hopefully with the campaign running, you will be able to capture them children. There is an important update that in addition of the new improvement thresholds to reward practices that can demonstrate an increase in uptake, but that doesn't hit the current targets. So about 1 in 7 practices could potentially benefit from the new system, where there's an increase in achievement since the previous year. You will still earn points and payment. In all cases, the points are awarded where improvement is more than 5% of the population. Points are gained more quickly in younger groups than for the preschool boosters. So you can see there, you've got your different thresholds. You've got your 5% to 18, your 5 to 23, and your 5 to 30%. So depending on what your achievement is, will depend on how much you get paid for practice. Unfortunately, there's still very little in the way of exception reporting for these indicators and none at all regarding parental choice. Increasing uptake of childhood vaccines is not easy, and we all know that. I struggle personally at my practice, but at least there is some reward for practices managing this, although it may be harder in future years to try and get these targets met, because we're going to be struggling getting them patients through the doors. There's been 32 indicators have been removed. So registers no longer pay for are your CHD 01, your diabetic 017, your heart failure 01, AF 01, your asthma 05, all your QOF registers. You're still clinically required to do this work, but there's no QOF income attached to this. There's been a review and there's some processes removed. So your cancer reviews have been updated and the 05 been removed. Depression review has been removed. Your SMI physical health checks have been removed, and your COPD referrals for spirometry has also been removed. There's been a funding shift. So QOF points that have been removed was worth 298 million, and it's been redirected into your global sum, your CVD indicators, and your practice level reimbursement schemes. This just means that there's less tick box income and more core funding to practices. So just a quick summary of the QOF. The 26-27 QOF changes focuses on obesity treatment and weight management, better diabetic care processes, optimise heart failure medication, stronger vaccination incentives, simplified cardiovascular indicators, higher thresholds of some indicators. The overall direction is more prevention, medicines optimisation, and population health improvement. So there is a shift from documentation to measurable clinical indicators and control, less QOF admin. So there's going to be potential for capacity gain, but funding now is less directly tied to activity. And practice relying on the QOF income, I would suggest that you remodel your income streams and focus on the high value indicators in your QOF. So for example, your CVD and your diabetes. Any questions before we move on to practice actions? I know there's a lot to take in. No? Okay. So immediate actions for your practice is suggested. Obviously, you don't have to do this, but recommendation that you review your triage and your appointment model, making sure that your practice is compliant with the contract changes. Audit your access data. Have you mapped your appointments? What is your current routine wait for a GP appointment? Access to your workflow capacity. Does your GP sessions reflect that of the BMA standard? Short-term actions, prepare for your QOF changes, let your clinical staff know of the changes and how this will affect them. Make use of your clinical templates and make sure your clinical staff are using the correct ones and catching all the data required. I say start as you mean to go on. There's nothing worse than being a practice manager and looking at your QOF later on in the year and seeing that all these patients have been seen, but they've not had the correct data captured when they came to see the nurse. Strengthen your PCN collaboration. Look at your risk stratification and your continuity of care. Your medium-term strategy. Implement demand modelling, calculate your GP sessions against your patient population. Have you got enough GP sessions for your population? Monitor your matrix, look at your data, go on GPAD, look on Curator, etc. You know, how are you doing as a practice? Try and have an idea of where you measure yourself, and that'll give you an idea of how you can map going forward. And develop your workforce plan. Do you have the correct hour roles for your patient population? As we said before, really difficult at the moment because we don't know funding, etc. So trying to make that decision early on is hard, but having an idea is good. And just the key implications for your practice and for practice managers. Workforce planning, potential GP recruitment opportunities. Remember that there will be a rise in demand for GPs in 26-27, especially with the changes to the hours roles. Ensure urgent care triage processes support same-day processes. Inform your staff of the changes within the contract, and make sure that they're aware of what your practice deems as urgent on the day, and that all urgent requests have to be dealt with on the day, no matter what time the request comes in. Really important as well to make sure your staff know about telling patients not to phone back the next day. That's in the core contract changes. Review your online access systems to remove your caps. Make sure that your triage forms are not switched off during opening times. Prepare for QOF indicator changes, and strengthen your vaccination and care home coordination. I would say get your nurses involved in this. They're the ones that are delivering it, therefore they should be involved in it. And ensure compliance with data reporting and operational requirements. Remember, Big Brother is now watching us all a lot more closer than they ever have. So it's really important that you know what your data is.